Hi, my name is Shaji Kumar. I'm a hematologist at Mayo Clinic in Rochester, Minnesota. I would like to discuss some of the results that we have seen with ABBV-383, which is a BCMA targeted bispecific antibody. As you all know, this class of agents have shown remarkable efficacy in multiple myeloma that is refractory to the currently used therapies. ABBV-383, which was formerly known as TNB-383B, is a BCMA CD3 bispecific monoclonal IgG4 antibody. Now, many of the bispecific antibodies that are being developed and going through clinical trials predominantly targets BCMA, while others target other antigens like GPRC5D and FcRH5. Now, ABBV-383 contains two BCMA binding domains and has a low-affinity CD3 binding domain, which is designed in such a way to maximize the killing of the myeloma target cells because of its specific myeloma targeting through the two BCMA binding domains, but at the same time mitigating off-target toxicity and decreasing the risk of cytokine release syndrome by virtue of having its low-affinity CD3 binding. In fact, preclinical results showed that the ABBV-383 can induce tumor cell death in xenograft models. And then, of course, in the phase 1 study that was previously presented and published, ABBV-383 monotherapy in relapsed refractory multiple myeloma had shown excellent activity. Now, in fact, at the most recent ASH meeting, we did present the results of the ongoing study, which is the phase 1 dose escalation and the dose expansion that is ongoing. So patients have been treated with ABBV-383 at several dose levels, including 20 milligrams, 40, 60, and 80 milligrams. The 60 milligram was considered to be the recommended phase 2 dose based on the DLT profile. And at the same time, we have seen significant activity at the 40 and 20 milligrams as well. So the ongoing studies are evaluating the different doses. Now, what we have seen is in a group of highly refractory patient population with a median of 4 to 5 prior lines of therapy, and with the majority having received monoclonal antibody against CD38, immunomodulatory drugs, and proteasome inhibitors, the overall response rate was about 56%, considering all patients. In fact, when you look at the 60 milligram cohort, it was 61%. Even when you look at the subgroup of patients who are triple class refractory, which was again a significant proportion of these patients, the overall response rate was around 55% in this patient population. And it's also important to note that these responses were fairly sustained, with a median progression-free survival of roughly about a year at this point, and the median duration of response not having reached in those patients with a response. The estimated 1 year duration of response is about 70% across these patient populations. So clearly showing high efficacy and high durability of response, including a significant number of patients who are MRD negative. From a safety profile, what we had seen with both with the structure and also with the preclinical studies is that roughly about 70% of these patients actually get cytokine release syndrome, and almost all the CRS that we have seen has been grade 1 or grade 2. And the other main toxicity that we have seen is hematologic, predominantly neutropenia and thrombocytopenia, but these tend to recover fairly early. We have seen similar rates of infections as what has been seen with other bispecific antibodies, but again, the majority of them tend to be grade 1 or 2. So overall, the efficacy and the safety profile of ABBV-383 is consistent with what was expected from the way the molecule was designed and from the results that were seen initially in the preclinical models. The trials are ongoing, looking at monotherapy with ABBV-383 as well as combinations of 383 with other standard of care agents, and hopefully in the next few years the phase 3 studies will be complete as well.